Welcome to The Coalition. This is a talk show dedicated to discussing health, wellness, and inspiration. I'm your host, Dr. Shani Belgrave. Hello, everybody. Welcome to The Coalition. I'm your host, Dr. Shani Belgrave. I am a bariatric and minimally invasive surgeon in Atlanta, Georgia. You can learn more about me and get connected at www.drshanibelgrave.com. I am delighted to welcome to the show today Dr. Michelle Glasgow. Dr. Michelle Glasgow is an accomplished gynecologic oncologist who joins the show to share her expertise on cervical cancer right on time for Cervical Cancer Awareness Month. Dr. Michelle Glasgow, thank you so much for returning to the coalition.
Thank you for inviting me to speak again.
Thank you so much. So you already know your episode on endometrial cancer was a big hit. So super excited to hear what you have to share. And of course, I'm going to pause and give a shout out to Brown University. Both Dr. Michelle Glasgow and myself did our undergraduate and medical school at Brown University. So once again, this is a full circle moment from Providence to Atlanta.
Thank you for having me.
So Dr. Michelle Glasgow, for viewers who may not be familiar with who you are, can you please get us started by telling us a little bit about who you are and what you do?
Yes. As you mentioned, I'm a gynecologic oncologist and I practice at Northside Cherokee in Canton, Georgia. And I treat women with gynecologic cancers. So, as we mentioned, cervical cancer, which we'll talk a little bit more about shortly, also endometrial cancer, ovarian cancer, vaginal and vulvar cancer. I perform surgery as well as administer chemotherapy. And then I also care for women with complicated gynecologic histories, which are benign. So for instance, women who have very big fibroid uteri, I'll perform surgery on them, or if they've had multiple abdominal surgeries and have mass, which is benign, but I may also take care of them as well.
Wonderful. Well, we are very grateful to have a guest of your caliber on the show. So can you please get us started by telling us, first of all, what is cervical cancer?
Yes. So cervical cancer refers to cancer of the cervix. The cervix is the lower part of the uterus. Women can think of the cervix as if they're pregnant, the cervix is what dilates and allows an infant to pass from the uterus through the vagina during delivery. Cervical cancer is preventable cancer. It's the only truly preventable gynecologic cancer. And as such, it is a great passion of mine to discuss how it can be prevented. Treatable, but also preventable, which is unique.
Well, this is very good information. So when you say that it is preventable, let's talk a little bit about the scope of the problem. How many people are affected?
Yeah, no, for sure. So in the United States, between 12 and 13,000 women will be diagnosed with cervical cancer each year, and about 4,000 women will ultimately die from this cancer each year. But the numbers of women who are both diagnosed and then the numbers of women who die from this cancer have steadily been declining over at least the last 10 to 15 years. And that is because of increased methods towards prevention. So in terms of prevention, in 2006, the Gardasil vaccine was approved by the FDA, and that is a vaccine which targets the HPV virus. Now, the HPV virus is the main cause for most cases of cervical cancer. The HPV virus is a sexually transmitted virus, and most people will be exposed to this virus at some point in their lifetime. And there are over 150 strains of the HPV virus, or when I say strains, like different forms or types, but there are certain ones which are known to increase the risk of cancer. And the Gardasil vaccine targets 9 of those virus, two of which don't cause cancer but can cause genital warts. And with the advent of the vaccine, we are seeing the numbers of women who are both being diagnosed as well as the women who are succumbing to cervical cancer. It's steadily declining. So that's
great news.
that. But also, cervical cancer can be detected in a precancerous phase, and it can be treated, the precancer, before cancer is formed. And that is why it is really a unique gynecologic cancer and a preventable cancer at that. So I highly recommend routine pap smears. Pap smear is a screening test for precancer of the cervix and cervical cancer. Before most cases of cervical cancer develop, they actually go through a precancerous phase, which can last like 5 to 10 years. And that's an opportunity, again, when precancer can be detected and treated to prevent the actual formation of cancer. And it's just a simple pap smear. But I always tell women that when they go to see either their OBGYN or their family doctor, or if they even go into the ER for some gynecologic issue, they may undergo a pelvic exam, but a pelvic exam is not necessarily a pap smear. A pap smear is when a brush is inserted into the cervix and cells are collected, which are then tested for any precancerous changes as well as the HPV virus. And then based on those results, precancers can be found and then treated.
So, how often should women be getting pap smears, and at what age does that start?
That is a really good question, a very controversial question, I'll say. So women should not, women should start having routine pap smears at the age of 21.
Okay.
And they should continue having routine pap smears until the age of 65.
Mhm.
In terms of the frequency of pap smears, this is where the controversy occurs. There are multiple different organizations which give different guidelines. For instance, there's ACOG, there's the USPATF organization. Many organizations give different guidelines on the frequency of pap smears and whether women should undergo primary HPV testing, which is just testing for the HPV virus, or if they should also undergo cytology, which is testing for abnormal cells. Um, Generally, for women in their 20s, if they have normal pap smears, they can have pap smears checked every 3 years. And then after the age of 30, they can undergo pap smears every 3 to 5 years if they are normal. But according to the various guidelines that are out there, but if you talk with individual providers, GYN oncologists, general OBGYNs, you'll see that what is actually performed in practice is very different. There are many providers who still perform pap smears every year, and there's some who may perform them every 2 years. And part of the reason is because of the concern of missing a cancer or cancer developing, or even a cancer developing in that 3 to 5 year span when a woman may not be undergoing a pap smear, as well as lack of reliability. Sometimes women don't remember where their last pap smear was, when it was, or where it was, and the provider can't obtain those records for confirmation. So I'll just say that there's a lot of variation out there. Now, for women who have abnormal pap smears, there's a completely different algorithm in terms of the frequency, because depending on what the abnormality may be, they then may need to undergo something called a colposcopy, which is a closer examination of the cervix in the office using a special microscope and applying essentially acetic acid or vinegar to the cervix. And anything that looks abnormal will change its appearance when the acetic acid is applied to the cervix, and then a biopsy can be performed. And then based on that biopsy, additional treatments will be recommended.
Mm-hmm.
One thing I will add is that, let's say a woman has always had normal pap smears and undergoes a total hysterectomy, which mean when I say total, I mean removal of the uterus and the cervix. I think I mentioned when we last spoke, removal of the ovaries. It's called an oophorectomy, and salpingectomy is removal of the fallopian tubes. But when a woman undergoes a hysterectomy, removal of the uterus, the cervix, and never had any abnormal pap smears in the past, She does not need to continue having pap smears after the hysterectomy. But if she had a hysterectomy, super cervical hysterectomy, and still has her cervix in place, she does still need to continue having pap smears according to the guidelines. And if she had a hysterectomy performed for a precancer of the cervix, it's recommended that she continue having annual vaginal pap smears for at least 20 years because of the potential risk of developing precancers of the vagina.
Okay.
No.
So going back to the vaccine,
Mm.
at who gets the vaccine and what age?
So the vaccine is approved now for individuals between the ages of 9 and 45. Ideally, it's given to boys and girls around the ages of 11 and 12. And the idea is to vaccinate children before they have exposure to the HPV virus. When the vaccine is given at that age, it's 2 doses given between 6 and 12 months apart. And then when it's given after the age of 15, it's a 3-dose vaccine. And I emphasize that it's recommended that both boys and girls, men and women, receive the vaccine because both men and women carry this virus. And it's very difficult to identify when you may have been exposed, but anyone can be exposed, and most people are exposed at some point in their lifetime. Most people do clear it, but it can persist in some and then develop and then put patients at risk, or women as well as men, at risk for different cancers or precancers.
So how
And
does this virus affect men?
so it can cause head and neck cancers like throat cancer. It can cause penile cancer, and it can cause anal cancer. And just to go back to women, HPV can also cause anal cancer in women, as well as cancer of the vagina and cancer of the vulva or the labia.
Fascinating. Well, really good information.
Mhm.
And so are people supposed to be getting these vaccinations through their primary care doctor?
That's a good question. It's very variable. Usually for children, it's brought up in the pediatrician's office, and usually it is available there. Um, but for adults, it may be available in primary care doctor offices. It may be available in OBGYN offices. Um, for many patients I see, we'll actually refer patients either to our infusion center, or sometimes patients will receive them at the health department.
Okay.
Yeah.
So I know you said HPV is one of the main risk factors for cervical cancer. What are some other risk factors?
I'll say the number one risk factor after HPV virus is not being screened, not going to see your gynecologist or primary care doctor for a routine pap smear. The most advanced cervical cancers, which I see, are in women who haven't seen their gynecologist since they delivered their last baby 35 years ago. That is really one of the biggest risk factors. Another big risk factor is smoking and tobacco use.
Mhm.
Women who smoke are at their risk of cervical cancer is double compared with women who don't smoke. And I would add that with the advent of other substances like vaping, we don't know about the link as yet, but I feel personally that that also increases your risk of cervical cancer. And the last risk factor I will mention is immunosuppression. So
Mhm.
women who have a diagnosis of HIV or AIDS, or have undergone, let's say, like a kidney transplant or a liver transplant, and have to be on like anti-rejection immunosuppressant medication, they are also the much higher risk of cervical cancer.
Okay, well, that's all good information to know. So, ideally, this is something that we either want to prevent or catch early. In
Yes.
people that have progressed beyond that stage, what are some of the signs or symptoms?
So for early stage cervical cancers that are, let's say, detected after they undergo an evaluation of an abnormal pap smear, they may not actually have any signs or symptoms. When women have signs or symptoms, that usually indicates a um, a cancer which may be locally advanced or metastatic. So, a common sign is abnormal bleeding, postcoital bleeding or bleeding with intercourse, abnormal discharge, like a foul, very foul smelling discharge, can be a sign. Also, pain, back pain can be a common sign, or pelvic pain, and or changes in bowel movements also. But usually, when women have those signs or symptoms, it may be that they have actually like a bigger tumor on their cervix, or they have local spread of the cancer lateral to the cervix, and it may be affecting like the ureters or the kidneys or the bladder.
So in those instances where it has spread or is large, what are the treatment options?
First, I'll say for early stage cervical cancers, women are surgical candidates. And if they have not completed, if they desire to have children in the future, they may be candidates for like fertility sparing surgeries, like a conionization, just removing a part of the cervix, or a trachelectomy, which is removing the whole cervix. And then if they're early stage, they may also be a candidate for either a simple hysterectomy or radical hysterectomy, depending on the full extent or the full size of the tumor. Um, Radical hysterectomy essentially simply meaning removing more tissue to get negative margins. But for locally advanced cervical cancers, which have spread lateral to the cervix, within the pelvis, into the vagina, or if they are higher stage, like a stage three, let's say like blocking the ureters, or even if they spread to lymph nodes, um, they're not candidates for surgery at that point. And usually the treatment involves a combination of radiation with chemotherapy to shrink the tumor. And those treatments can be curative as well. But those women, because they're a higher stage, they're at a higher risk of recurrence in the future. There's been a lot of development of newer treatments and newer treatment regimens in the last few years. So I'd say that chemotherapy and radiation is an alternative to surgery for higher stage cases, but sometimes we'll also give chemotherapy first to shrink the tumor, and then chemotherapy and radiation. Or sometimes we'll give chemotherapy, radiation, and immunotherapy, and then those patients will continue on immunotherapy for a couple of years after completion. And for the highest stage patients, like stage four, we'll usually do what we call quadruplet therapy, which is two chemotherapy drugs and then two immunotherapy drugs.
Okay. Lots of good information. So, Dr. Michelle Glasgow, as always, you bring a lot of good insight. Thank you so much for sharing your expertise. What would be your takeaway message for Cervical Cancer Awareness Month? What should everybody know?
My takeaway message would be twofold. One is, if you don't remember when your last pap smear was, or if you are overdue to see your OBGYN, call and make an appointment, because it's all about prevention. And this is truly a preventative cancer. This cancer can be caught in the precancerous phase. I can't emphasize that enough. But the second take home message would be, as I always say, know your body. It's all about recognizing what's changing, what's different. If all of a sudden you had regular periods and you're starting to have bleeding in between periods, that could be a sign of cervical cancer. Or if all of a sudden you start to have a lot of bleeding after intercourse, another sign. If you have just a new back pain which won't go away, just don't ignore it. Sometimes you may have to see a few doctors to figure it out, but I would not ignore anything that is new or changing.
Listen to your body. So,
Yeah.
I'm glad you brought up the screening again, because I know you said that's controversial, but what does Dr. Michelle Glasgow recommend for cervical cancer screening in terms of interval or frequency?
So for a patient who is reliable and where you can obtain the last pap smear report to confirm what that result was, I generally would recommend every 3 years. If in the setting of normal pap smears. If it's abnormal, then it really depends on what the exact abnormality is. There is a group, it's called ASCCP, which puts forth guidelines on not just the screening, but also the management of abnormal pap smears. And that's what I follow.
Wonderful. Well, it is always a delight to have you on the show. Thank you so much for joining the coalition. Now, see, you have so many different areas of expertise. I'm sure I can bring you back for a third.
Thank you, Dr. Belgrave.
Thanks so much. We'll see you next time.
Happy New Year.
Happy New Year. Well, everybody, thank you so much for tuning in to another impactful episode of The Coalition. You can stay connected with me at www.drshanibelgrave.com. You can get connected with Dr. Michelle Glasgow, Gynecologic Oncologist, by contacting Northside Hospital, Cherokee. Thanks so much for watching. Make sure that you share this episode with at least one person to raise awareness for cervical cancer. I'll see y'all next time.